Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro APM experts for Ukraine, Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, Rise Contra Cancer with SweetCare support are excited to present the ninth lecture in this course, and the topic is pancreas and liver SBRT. We have two amazing speakers from University of Michigan today, Professors Daniel Chang and Kelly Paradis. Dr. Daniel Chang is currently the Isidore Lam Professor and Chair of the University of Michigan Department of Radiation Oncology. He received his MD from Wayne State University in 2002 and completed his residency in radiation oncology at the University of Florida in Gainesville. He then joined the Department of Radiation Oncology at Stanford from 2007 to 2022, having previously served as the Residency Program Director and Vice Chair of Clinical Operations, where he was also the Sue Bob McCollum Professor in Radiation Oncology. We really miss him at Stanford currently. Dr. Chang's primary research interest is in advanced radiotherapy techniques, primarily SBRT. He has led several studies investigating and establishing efficacy and safety for SBRT for liver and pancreatic tumors. His other research interests include normal tissue tolerances, quality of life after radiotherapy, combining radiotherapy with targeted agents. In addition, he has strong interest in use of radiotherapy, particularly in combination with systemic agents in patients with metastatic disease. Thank you so much, Dr. Chang, for agreeing to teach this lecture. I know you're a very, very busy person. We really appreciate having you here. And again, Stanford misses you. And our second speaker today is Dr. Kelly Paradis. She's a clinical professor in the Division of Medical Physics in the Department of Radiation Oncology at the University of Michigan. She received her PhD from University of Michigan Department of Physics in 2010 and completed her residency in therapeutic clinical medical physics at the University of Michigan in 2013. She worked as a staff medical physicist at Trinity Health in Mississauga before returning to the University of Michigan as a faculty member in 2014. At Michigan, she leads the re-irradiation special medical physics consult service, serves as the Department of Radiation Oncology Associate Chair for Wellbeing and Engagement, and is a clinical faculty ombud at the medical school. Dr. Paradis' primary research interest is cumulative dose assessment in re-irradiation. She serves on the steering committee of a re-irradiation collaborative group, or RECOG, and she has published numerous peer-reviewed articles on this topic of re-irradiation. Thank you so much, Dr. Paradis, for preparing the lecture today. So very excited to have both of you. It's an honor for us. So we're eager to learn about pancreas and liver SBRT. The podium is yours, Dr. Chang. I'll stop sharing.
Thank you very much, Natalia. Of course, it's yes, great to see you again. And I think I've probably met a couple of the folks in the audience, perhaps over the years. You know, Natalia, Dr. Kovalchuk has been an amazing supporter of Ukraine, and I still remember the phrase I'm supposed to say is Slava Ukraini, right?
Yes, Slava Ukraini. Heroyam Slava. Thank you so much.
Welcome. Okay, well, it's a pleasure to be here. I changed the order around. It said liver, pancreas, SBRT, but I'm going to start with pancreas. This is obviously challenging just because we are really putting two different topics under one talk, but a lot of the principles and concepts will be overlapping. Again, our pleasure to be here. And a lot of this work was stuff that I had done at Stanford and things that hoping to continue while being here at Michigan now for almost 3 years. I don't know if it's, oh, hold on, what's going on here? I don't know if it's customary, but we put our disclosures. These are disclosures for myself and Dr. Paradis. So start with pancreatic cancer. And these are just statistics that I always start with because I just think it's very sobering and it's important to understand what a big problem pancreatic cancer is, particularly here in the United States. So these numbers are for the US. Interesting to know what they might be for Ukraine and other parts of the world. But there's been a significant increase in pancreatic cancer incidence over the last 10 years. You can see back in 2014, the numbers were about 46,000. And now in 2024, last year, that number's jumped to 66,000. So that's, a 40+% increase over the last 10 years for reasons we don't quite understand. But what's more troubling is the high incidence of death. So pancreatic cancer now represents, while it is the 9th or 10th most common cancer, it is actually the 3rd leading cause of cancer death with 47,000 back in 2020, now 51,750. And what's scary about that is that the number 2 cause of cancer death in the US is colorectal cancer of 53,000. So if you look at those two numbers, the projection is that before the end of this decade, pancreatic cancer will overtake colorectal cancer and now become the second deadliest cancer in our country. And it just goes to show you just how closely the death numbers match the incidence numbers, which tells you there's a lot of progress that still needs to be made. Surgery, of course, is the only realistic curative option, but a small minority of those patients present with resectable disease. And you can see historically the numbers of the overall survival numbers, the median overall survival numbers for the different groups were quite low. So stereotactic body radiotherapy, has emerged with the advancements in technology. It has emerged as a viable treatment option for patients with locally advanced disease. And that's really how it first kind of came about. And so you can imagine a very typical tumor that we might see is, this pancreatic tumor right here. You can see kind of this hypodense region. And the problem with it is that it's encasing this superior mesenteric artery. And it's because of this encasement, that's what makes this tumor unresectable. And because of that, that has the biggest impact on what the survival for these patients will be. And this case is kind of what the vignette is about, is really a patient that presents with a pretty small tumor, but because of where it sits, it is attached to this blood vessel, and so a surgeon would not be able to resect this immediately. And so there's discussions about whether this would be borderline or potentially resectable versus locally advanced, which means unresectable. And the question just is, what is the optimal, treatment technique that we would use for this, right? And back in the day, we might do something like, 5 weeks, 6 weeks of chemo radiation, going to 50 gray, 54 gray. And the outcomes for that really aren't that good. And so SBRT really came about because of the idea that we can try to get more dose because we know that radiation is not that effective for pancreatic cancer. And just to kind of go back to radiobiology 101, I think we all know this from our initial radiation biology education, which is that it's always better to give treatment in fewer fractions than in more fractions, because each time you have to give dose, you have to kind of go across this little radio-resistant shoulder, and you waste that radiation trying to overcome that. And so you can see that the efficacy of killing cells is not as good if you give the same dose, 8 gray, spread out over 4 fractions, versus if you give it over 1 fraction. And so the idea behind SBRT is that by hypofractionating, we are going to be reducing the number of fractions and hopefully making it more effective. The advantages of pancreatic SBRT are that you can get a higher biologically equivalent dose for part of the reason that I just said. For patients, it's much easier than coming in for 5 days rather than 5 weeks. There is improved cost effectiveness based on some studies that we had done, improved quality of life because there's going to be reduced toxicity when you do treatments in a shorter time span. And you minimize interruptions of chemotherapy. And this has really been kind of one of the major advantages to a short course of radiation, because we know systemic therapy is so important for pancreas cancer because of the high risk of distant metastases. You do not want to interrupt multi-agent chemotherapy for up to 2 months or more with fractionated chemoradiation with a very mild chemotherapy with 5-FU. Nowadays we know FOLFIRINOX and gemabraxine, these are very effective multi-agent chemotherapies, and we don't want to disrupt or interrupt that if that's doing a good job of controlling the metastatic disease. The disadvantages, of course, are that it's technically more challenging, more resource intensive. There's potential for risk of toxicity because you're giving very high doses to very sensitive parts of the body. You can see the duodenum, bowel, stomach, they all kind of sit in this area. And so there's always risk, especially with a lot of uncertainty with motion management and anatomic positioning, that there's risk for toxicity. And then also on the other side of it is the potential for missing the tumor, so causing a marginal miss if you don't completely hit the tumor with your prescription dose. So the advancements in radiation that really allowed for SBRT is really improvements in image guidance. We have better imaging to align the tumor to ensure precision and accuracy. The use of implanted fiducial markers, which has played an important role. Respiratory motion management, there's a number of different ways to do that. 40 CT became more standard, gating, respiratory tracking or breath hold, improved technology, different types of systems are now out there that can deliver radiation more accurately, faster, et cetera. And then, of course, the early studies with SBRT have now sort of, I think, proven that the local control rates that you get with SBRT, for all the reasons that I said before, are better than with fractionated radiation. So a quick timeline, just for those that don't know. First reports of SBRT came out, we've been doing SRS, radiosurgery in the brain for, many, many decades, since the 60s or 50s, I think. But it wasn't until in the early 90s that the Swedish group reported using this really high-dose stereotactic body radiotherapy for lung tumors. The first patient actually treated with lung and liver SBRT was first reported in 1998. And it was around this time that one of the physicians at Stanford actually did the first pancreatic SBRT case. That was Quinn Lee, by the way, Natalia. And then in 2004 was the first, prospective clinical trial for pancreatic SBRT. And that's really kind of where things started to take off at that point. So a lot of the early studies, many of them originating from Stanford, but then many other places also picked it up, started using different SBRT hypofractionated regimens. And you can see, I kind of stopped tracking this table after 2013 because there are just so many studies now, but they all kind of show a very similar theme. You can see very high doses. The doses did vary, but they were started off with 1 fraction, went to 3 fractions, and then 5 fraction became much more commonly used. But you can see the local control rates, for the most part, are quite good. They hover around like 80. Nowadays, modern SBRT, you should be shooting for around 80 to 90% local control at 1 year. And that's better than historically what we've seen with conventional fractional radiotherapy, where you're probably lucky to get 50% local control. Overall survival, it varies, but I think a lot of that's dependent on chemotherapy and other factors. But I think the other big thing to highlight is obviously what's the risk of toxicity. And you can see that some of the numbers in these studies do show some significant risk for GI toxicity, and the type of toxicity we're talking about. These are going to be late toxicities that can cause things like ulcer, bleeding, potentially some life-threatening complications. And so these are important things that obviously we have to pay very close attention to. So the Stanford experience, which is the experience I lived through when I first arrived there, the initial studies use single fraction 25 gray, which, I think nowadays many of us would feel like that's probably quite high and quite risky, but this was originally in the early days. This was what the protocols were. And these studies did show that yes, there certainly was a risk of toxicity, and the local control rates were good, but also the survival numbers also were not really improving much. So one of the first studies I did when I was there, we did kind of a overall sort of consolidated experience report of our about 77 patients treated with that single fraction regimen. And I think the biggest findings from here are that you certainly can get a high rate of local control. So freedom from local progression was, around mid-80s, 84%. If you looked at just isolated freedom from local progression, it was about 95%. But I think the big thing that really kind of opened our eyes was the fact that you were seeing pretty high rates of grade 2 or higher toxicity. And a grade 2 toxicity was an ulcer. So an ulcer, or then a bleeding ulcer, which would be grade 3. Grade 4 would be a perforation. So these are pretty serious toxicities. And you can see at 12 months, those rates were hovering in around the 25% range. So quite high. And I think it really kind of forced us to really start thinking about fractionating the dose more. And so that's what we started doing. And so a few years later, we wanted to compare that experience. And so we took about 170 patients or so. Again, about most of them, the 76 patients from before that were treated with single fraction, and we have 90 patients multi-fraction. Multi-fraction meant treating them to either 33 gray or 40 gray in 5 fractions. So it was really 1 fraction versus 5 fractions primarily is what the study was comparing. And the big finding really 12-month cumulative incidence of recurrence for local recurrence was only 10%. Still around in percent control. At the toxicity, see that cumulative toxicity rate here is about 26%, very similar. Very clearly showed that multifraction was going to reduce your risk of toxicity. And so that really kind of helped solidify that being our standard of care. So 5-fraction, as you'll probably see across most practices that use SBRT, 5-fraction is the way to go. So the question really is just the concept of ablative versus non-ablative radiation. There's a saying in the US, in America, we say there's more than one way to skin a cat, which just means there's different ways that you can deliver ablative radiation. SBRT is the one that we're here to talk about today mostly, but there are other other groups that propose really, it's not so much about using SBRT or using 5-fractions, it's just can you get a significant amount of dose or a high enough BED into your tumor? And there's been lots of studies looking at conventional radiation, hypofractionated radiation, SBRT, showing that you do need, if you can try to get doses closer to 70, 80, 90 gray BED, then that's going to be what helps improve your local control and some people think survival. So I think generally the community accepts that getting above 70 gray BED is considered ablative, although I think many would prefer going higher if they can get to like 90 gray or higher. Obviously, we're going to be limited by what we can deliver because of the toxicity risk. So, the question that a lot of people ask, at least in the early days especially, was, what are the ideal patients for pancreatic SBRT? You're talking about very high doses of radiation, very concentrated. So certainly you can see like a case like this would be ideal, right? You can see a very nice hypodense tumor here. You can see the normal pancreatic head here. And the stomach, although it's nearby, that gap there, that's probably at least 5 millimeters. Which for us in the SBRT world, that's like a mile, because that's quite good, and allows us to get enough sparing that you can create a good dose gradient. You have a good planner, good physicist, good dosimetrist. They should be able to kind of find a way to get radiation in there without, while protecting the stomach. However, that is not reality. I would say the vast majority of cases are going to look something more like this, which is, you see a pancreatic tumor, and you can see probably on, about 270 or 240 degrees of the tumor, you don't have bowel, but you can see right along here about this 120 degrees of it, you have stomach, that's probably small bowel right there. And so, these are the type of cases that you're typically going to see. And obviously, if you don't feel comfortable giving high doses of radiotherapy, if you don't feel like the resources are there or the comfort level, the expertise, certainly kind of more conventional chemoradiation is perfectly safe and a very acceptable treatment approach. But if you feel that there's the ability to kind of plan and have good setup accuracy, good imaging, good respiratory motion management, you can definitely try to do a case like this. And this is a case that I did treat with SBRT. You just have to be very careful about how you protect the bowel. And then for the setup when on the daily treatments, you have to make sure that you can image and make sure that the alignment is very good. And then this would be kind of like an extreme case of a patient, with a pancreatic tumor that's pretty much invaded and surrounded the duodenum. And so I kind of highlighted that there. That's the duodenum there. And you can see it's getting completely kind of gobbled up by the tumor. And so this is a case that I said, would not be good for SBRT. And I think we wound up just doing a gentler kind of palliative regimen for a case like this. So hopefully that gives you kind of a different flavors of what's out there. It obviously, as you do more of this, you'll have a better understanding of what you think you can do safely and what you probably cannot. So obviously the challenge of escalating radiation dose, we kind of talked about proximity of the tumor to radiosensitive GI organs. I think the other thing that, Kelly may talk about, but I think we all understand is that while we do have better image guidance than before, it's still not great. When you use kind of a standard non-gated cone beam CT, this is the typical type of cone beam CT we see in the abdomen. And, you could not figure out where that tumor was. And so this would be very difficult for us to be able to know if the tumor is aligned properly. We don't have any internal imaging during treatment. And you can't really modify the treatment plan once you start. So, this is actually pancreatic cancer was one of the original sort of indications for more sophisticated advanced radiotherapy techniques, including adaptive radiotherapy. And so I'm not sure if anyone has experience using the MR-Linac, but if you've gone to Stanford, they do use that now routinely. But the MR-Linac or MR-guided radiotherapy has become a very, I think, a very important player in the pancreatic SBRT space. And just because MRI just gives you better, more accurate soft tissue imaging. You can see better anatomic variation. You can do gating, and you can do, really the important thing is the online adaptive planning, meaning that you can actually modify your tumor, or I'm sorry, modify your plan based on changes to the tumor positioning, or more importantly, changes to the surrounding normal tissue. So you can see this example, this is a CT sim. You would contour your tumor and you would contour all the normal structures, but then on the day of an MR, you can see that now, look, everything has changed. Clearly, the bowel and the stomach are not in the same place anymore. And that could be good or bad, right? It could mean that the tumor is now closer to bowel, and the treatment you deliver could be dangerous. Or on the flip side, if the bowel has moved away from the tumor, it means that you could give higher doses and you could actually change the plan. And so here's an example of a plan like that, where you can see a pancreatic tumor. This is the initial plan. And if you, and so on the day of treatment, you can see now the stomach has moved more into closer to the primary tumor. So if you were to give the plan that you had planned, you would see now that a lot of this stomach would actually be getting very high doses of radiation. And so what MR-Linac technology can do is you can now adapt that plan. So on the day of treatment, you see that the stomach has moved closer to the tumor. You can actually change the plan, and you can see now the dose distribution has changed. And so you can see that you can actually get better coverage of the target, but probably more importantly, you can get more sparing of your stomach. And you can see that the predicted dose of like the stomach right there in that small blue line, with the adapted plan, you can actually get that lower. And so that's the advantage of something of a technology like this. And this has been tested. The phase 2 SMART trial, single arm trial, of the phase 2 prospective study using 50 gray and 5. So it was actually quite a high dose of radiation, but 100 gray BED, 50 gray and 5 fractions. And the primary endpoint was primarily looking at the risk of grade 3 or higher toxicity. And what they found was that overall survival was pretty standard, 40% at 2 years, which is pretty reasonably good, actually, if you think about it. Local control at 2 years was pretty encouraging, near 80%. So that also was very good. But I think the other major finding was that, I didn't say that here. The other major finding was that they found no instances of grade 3 or higher toxicity with this treatment approach. So the fact that you could deliver a very high dose of radiation, 50 gray and 5, without any grade 3 or higher GI toxicity is a pretty strong evidence that this treatment technique was very successful, especially in the setting of very encouraging local control rates. So kind of back to what I said before about more than one way to skin a cat. Again, you can give ablative radiation. Ablative just means that you're giving a high enough dose. And so other investigators, particularly those from Memorial Sloan Kettering, which is in New York, they actually are a proponent of using this more fractionated approach, either 25 fractions, depending on where the tumor is close to bowel, or 15 fractions. But the goal is to basically try to get up to a BED of about 97.5 gray with concurrent 5FU. So very aggressive treatment. And basically 75 gray and 25 fractions if the tumor was very close to bowel, within 1 centimeter. Or if it was further away than a centimeter, it was felt to be safer, and you could do 67.5 gray in 15 fractions. And you can see that the results are here, and mostly the cumulative incidence of local progression at 1 year was about 17.6%. So that's means about a 83% local control. And at 2 years, it was close to 70% local control. So pretty encouraging, better than historic numbers. But I think where there's probably having some current discussion right now is, is this hypofractionated regimen better, or is it is a more SBRT type of approach better? Needless to say, again, I don't know if that is worth a major, battle that we have to really fight. I think really the concept is dose escalated radiotherapy better than standard dose radiotherapy? And that's actually going to be tested. There's an NRG trial that's been opened, and we're going to be hopefully be opening that up here at Michigan. But it is a randomized trial really testing the role of dose escalated radiotherapy. So patients after chemotherapy, 4 to 6 months with locally advanced pancreatic cancer, they will be randomized to either standard of care, which could be anything related to chemotherapy, further chemotherapy. They could be observed, or they could give, it's called low dose chemoradiation, but that just means standard dose chemoradiation, your 50 gray with 5-FU. And they're testing that against dose escalated radiotherapy, which could be 50 gray and 5 using MR or CT guidance. You can do online adaptive, or this 75 in 25 fraction regimen as another way to do it. So this will be an important study for us, I think, to really show, hopefully, that the role of radiotherapy it will continue to be important for locally advanced disease. Okay, so now I have my first question. Hopefully you remembered everything I said. Which of the following is true regarding SBRT? Oh boy, wow, nice. Let me move that out of the way here, sorry. A, fractionated SBRT has higher rates of GI toxicity compared with single fraction SBRT. Pancreatic cancer is the third most common cancer diagnosed in the US. One of the major advantages of SBRT over conventional radiation is the higher biologically effective dose. Or D, an indication for pancreatic SBRT is tumor invasion into the duodenum. How much time should we give?
Yeah, so we typically wait until 80% approximately answers. So we'll
Gotcha.
wait.
Okay.
Mhm.
Oh, okay.
Almost there.
Yeah,
Yeah. So we
okay.
have almost 70, few more answers.
Yeah. All right, we hit
All
it.
right. So ending the poll, sharing results, and a majority, 69% answered C.
Yes, I would agree. So that's the right answer. And hopefully that was kind of clear from what was showed. Obviously A is the opposite, as fractionated SBRT actually has lower rates. Pancreatic cancer is the 9th most common. It's the 3rd deadliest, but the 9th most common cancer diagnosed. C was correct. And then D obviously is we do not want to do SBRT for these types of patients. So, okay.
Excellent. Thank you.
All right. Oh, that was smooth. Okay. Okay, so the things we've learned about SBRT over the years, over these last, 15 to 20 years or so. So quality of SBRT, how it's delivered, how you plan, how you set up, all of these things. I mentioned before about how risky it is if you're trying to keep very, very tight millimeter type margins. Quality is going to be extremely important. And, these are what the early day pancreatic plans were like. You can see there's very little margin for error here. And that's great because you're keeping toxicity down. But the thing we've learned over time is that there's a downside to that, right? And obviously that's what I mentioned before about marginal misses and other things. And so this was a study from China that had kind of a crazy study. It reported like 500 or so local recurrences after pancreatic SBRT. They didn't report like what's the total number of patients they had. So I don't know, like, is this a data set of 5,000 patients or 1,000 patients? But they talked about 500 local recurrences, and they mapped them, based on, on the CT scan relative to the tumor and what other regions it was nearby. And you can see, celiac artery, superior mesenteric artery, or both, portohepatis, splenic, splenic vein retroperitoneum, or splenic nodes, I should say. They mapped them out, and it shows that, all of these represent pretty significant areas that recurrences can occur. And many of these are in nodal regions. They're in the elective nodal space. And I kind of implied this before, but, back in the day, we just wanted to treat the tumor only, and we intentionally did not treat the elective nodes. So you were purposely leaving those out for the sake of safety, with the hope that chemotherapy would probably be the main treatment that would cover those. But we've learned, we are learning that local regional recurrences, or I should say regional recurrences, actually are more common than we think. And you can see that they all happen within, a centimeter or so of these vascular and other structures. And so it tells us that these lymph node regions could be an area of risk and an area of opportunity for us to treat. Around that same time, there was this prospective study that came from Cincinnati. They looked at preoperative SBRT followed by surgery, and they found a pretty disturbing high rate of local or marginal recurrences. After 2 of 8 patients that they initially enrolled had those marginal recurrences, so they decided to add this CTV, which was treated to a lower dose of 25 gray and 5 fractions. And that was treated to the entire head and body of the pancreas, and you included the SMA and the celiac arteries. And they found that there was a decrease in the number of recurrences after adding a CTV. These are both pretty high numbers, so I don't quite understand why they are what they are, but it's probably just because there's very few patients in the study. But 50% down from 80% with the addition of the CTV. The other thing they did was they mapped where these recurrences happened relative to the plan, and it certainly suggests that these areas were undercovered, which could have led to that recurrence. So the concept of elective nodal radiation came back into the world of SBRT. We had intentionally left it out, and now I think we've become more comfortable with the doses. We know what the plans can achieve, and now understanding patterns of recurrence, this concept of E&I started to make a resurgence, and it's something that we decided to do kind of as a standard of care at Stanford about, I don't know, 6 or 7 years ago. So all patients, in addition to getting their main tumor treated to 40 gray and 5 fractions, an elective nodal volume was added to cover all of the typical regions that you would expect for pancreatic cancer, your celiac, your SMA, your portohepatis, retroperitoneum, periaortic areas. And so these are what our volumes tended to start to look like. And so we did a study where we compared, we did a historical study, retrospective, comparing patients who were treated with SBRT and E&I, the elective nodal radiation. And we did sort of this matched control study comparing them to patients who had just SBRT to the primary tumor alone. And the big findings from this study were that if you look, while overall survival is no different, you can see the local progression starts to get reduced, not significantly, but it was reduced with the addition of E&I. You can see that the regional progression, so the lymph node regions only, that was nearly significantly improved. But when you combine local regional, you can see that cut the rate of local regional recurrence by half, which was statistically significant. So this was kind of really the first proof that came out that the addition of E&I did improve significantly the risk of local regional progression. So the concept of really making sure that we include this area has caught on and has become much more standard now in the protocols, including the NRG trial. And there's a concept of the triangle volume, which is a surgical concept, really to address kind of, extrahepatic neural tract spread. But it's bound by this, the celiac trunk and the hepatic artery. This is the SMA here, and then this is the SMV and portohepatis. And so this triangular volume is considered very high risk for subclinical disease, including lymph nodes and potentially neurovascular spread. So NRG came out just earlier this year with kind of a contouring atlas for dose-escalated radiotherapy. And, I just put it here. You can definitely take a look at it, but it just kind of describes what you might cover if this was like a head and neck or proximal body tumor, and then what you might cover if it was a distal body or tail lesion. So all the different areas that one would do. I'll just leave that there. Okay, so question 2. Which of the following is true regarding elective nodal radiation with SBRT for pancreatic cancer? Sorry, let me move this out of the way. Okay, E&I should never be done. E&I dose should be the same as the dose to the primary tumor. The inclusion of E&I improves overall survival. Or E&I should include the celiac, SMA, periaortic, and portohepatis lymph nodes. Almost there.
You tricked a little bit, I think.
Probably.
So we have 81% answering, amending the poll, sharing the results.
Okay, so
it's split.
Yes, the correct answer actually is D. Probably I was trying to trick you a little bit. So obviously A, that's not true because we just talked about now doing it. B is that I probably didn't say this as much as I should have or emphasized it, but the dose would not be the same. We would not treat the whole thing to 40 gray in 5 fractions. We actually standardly do 25 gray in 5, so it is a lower dose. The results I showed as far as outcome for E&I, it actually improves local regional progression, but it actually does not improve overall survival. Again, that is overall survival is primarily driven by systemic control, which is driven up by chemotherapy. So that's the reason why C is not correct. And then D, of course, is the correct answer. Okay, great. All right, and then I think the last section is really just some more practical stuff, which certainly we can talk more about too when Dr. Paradis gives her section. But successful SBRT or SABR minimizes volume of radiation. So back in the day, I told you we only used to focus on the tumor only, and we left out prophylactic nodal radiation. But since then, elective nodal radiation has become much more common, and in my mind has become the standard of care. You have to obviously account for organ motion. You do not want to have to treat the whole respiratory motion envelope, because that's just going to increase your risk of normal tissue exposure. You want to have sharp dose fall off gradients to allow for protecting normal tissue, and obviously you have to have good image guidance. Respiratory motion is really, really critical. I would not recommend doing pancreatic SBRT without some sort of motion management strategy. We know that the upper abdomen has very complex motion. Organs move in very, very unexpected ways, which you can definitely easily see on a 40 CT. So you have to have some strategy to compensate for that, whether it's abdominal compression, breath hold, respiratory gating, or tracking. And of course, the goal obviously is to reduce that margin, to reduce the risk of toxicity. And this is just kind of some of the different options. I'm not sure what your institutions have, but I've used kind of all of these before in some form or some version. For simulation, we usually will place fiducials. Back when we used to do them more standardly, I would say that the use of fiducials is going to be institution dependent. I think it does require some collaboration. It's going to obviously require collaboration with your gastrointestinal colleagues, who, if they can actually they have to be able to place endoscopically the fiducials into the pancreatic tumor. And so, that requires some comfort level and some experience. And then obviously you have to be able to do it in a timely manner. Once the seeds are in, you want to kind of let them sit for at least a week to settle, because they can move during that first initial period after placement. So you want to make sure that you have that all completely settled before you scan them. We simulate them, supine arms up, using some sort of alpha cradle arm or vac lock bag. And we do this biphasic or arterial and venous phase for planning. Or if you're not able to do that in your department, making sure you have the diagnostic scan or a good diagnostic pancreatic protocol CT scan available to help with target delineation. 40 CT if you have that. If you have PET CT, that can sometimes be helpful as well. And obviously you're there to assess position of the seeds. But the reason why the biphasic is so important is because normally if you just get a contrast phase CT, you're going to get the portal venous phase. But pancreatic tumors are best seen actually in the late arterial phase. And that's just because the tumors themselves don't really light up with the contrast. But what really lights up is the normal pancreatic parenchyma. So you can see the blush here initially with the contrast for the normal parenchyma. So because of that, you can see a very nice, split between the hypodense tumor and the brighter normal pancreatic parenchymas. And you might not necessarily see that. If you saw this, you might contour this whole thing as the tumor. So having the arterial phase really helps you define that. And obviously, the more you go this direction, the closer you're going to get to the duodenum right here. So it's really important to be able to have that. Oh, there you go. There's an arrow. So for pancreas and HCC, I'll skip this part when we talk about it for liver, but we generally do the arterial phase at around, it depends on how your institution does it. The timings generally are about 30 seconds after the contrast goes in. You usually get the arterial phase. The venous phase is usually done about 30 seconds after, so about 60 to 65 seconds after the contrast. So that's generally how, at least our protocol, I remember at Stanford, was. 40 CT would then follow. And then for planning, you would contour the tumor. So whatever visible tumor you see on a CT or a PET or an MRI, You would have an ITV if you need to do that. If you're doing gating, we would do sometimes usually between the 30 and 70 phases. We just add, and so with the ITV, from there we go straight to a PTV margin. We don't add any extra CTV to account for any tumor spread beyond the tumor itself. So it's just straight from GTV to ITV to PTV. But then now with the addition of a CTV lymph node region, we would include kind of what I showed you before about the different lymph node regions here. And then we prescribe, generally go for about 95% coverage of the PTV. And based on, in terms of dose constraints, these are dose constraints that we've settled on here. These are based on from some experience that we've done before, but the main ones I look at are Dmax of the duodenum and stomach. They're pretty much the same. I treat those organs the same: small bowel, stomach, duodenum, and large intestine, large bowel. We usually put the same dose constraints: Dmax of less than 40 gray, V33 less than 1 cc. And so, these are some of the plans that you might see. If you were just treating the tumor alone, plans might look a little something like this. You can see the fiducial implanted in the tumor. You can see here, this is a case where the tumor is obviously very snug against the duodenum right here. And you can see that the plan is obviously undercovering this portion of the tumor in order to protect the stomach there. And you can see that through that method, we were still able to meet our constraints. The Dmax was 39.6, V33 of 1.1 cc. And then, in other cases, you could consider doing some sort of a dose painting where, again, this was that case I showed you at the very beginning. You can see that the tumor, because it's right up against that artery, this is what makes this tumor unresectable. So you can imagine that if I really wanted to make this patient resectable, I would put additional dose right at that area in order to try to sterilize and get that tumor off the artery. And so we intentionally did this internal boost of 50 gray while treating the rest of the tumor to the standard 40 gray. And then with E&I, elective nodal radiation, these are what those types of plans typically look like. So again, you can still get 40 gray in your tumor while getting 25 gray around the elective targets. Okay, so last question. When planning a pancreatic SBRT case, which of the following is true? Patient should be simulated on an empty stomach. I may not have talked too much about that, but I may have put that in the slide. For the high dose primary target, additional CTV should be added around the primary tumor before expanding to the PTV. I specifically wanted to bring that point up there. The stomach and duodenum have different dose constraints, and the tumor is best visualized on the portal venous phase.
Yeah, let's see if people were paying attention. Looks like they were. Waiting for a few more answers. Okay, I'm ending the poll, sharing results. The majority, 47%, answered D.
Oh boy.
The tumor is best visualized on portal venous phase.
So the answer is actually A.
A.
Yes. And I actually realized I didn't emphasize this specific point. I think it was on the slide, but I didn't say anything about it. But yeah, we did. The patient will be NPO, or will be fasting or have an empty stomach usually about 3 hours before, because of the contrast that they get, and we want to continue to sort of reproduce those conditions, right? Because if you have a stomach that's full of food or water, then it's going to obviously distort the stomach and change the anatomy. So you want to make sure that they're the same all the way throughout all the fractions. And so that's the important piece and important lesson for there. B, I try to kind of emphasize that we don't have to add additional CTV to the primary tumor. We only add it for the lymph nodes. So you don't actually have to you don't have to add any more CTV to your primary tumor that you're going to prescribe to 40 gray or something like that. Stomach and duodenum have the same dose constraints. So I mentioned that I treat them all the same. And then the point I emphasized on that slide was that it's really that early arterial phase that you have to get in order to visualize the tumor the best. So that's why D is not correct. Okay. All right. How are we doing on time? Okay, so conclusions here. SBRT continues to be an important treatment for pancreatic cancer. I think it will continue to be used in the preoperative and locally advanced setting. Ablative doses of radiation, 72 gray or more, should be given to improve local control. I think elective nodes should be considered with SBRT, and I think it will continue to have growing roles in new settings, including, I didn't talk about this, but this is just kind of future forecasting, is just the role of SBRT for medically inoperable patients. So patients that are too sick for surgery, their tumor could be removed, but they're just too sick to undergo such a big surgery. Oligometastatic disease, there's data now showing that SBRT could improve outcome for these patients. And there's some new exciting data on the role of SBRT for pain relief by doing celiac nerve plexus block, which I think is really, really exciting. So with that, I was going to leave and go to the world of liver. Time-wise, okay, let me see how I can keep this moving along here. Okay, liver radiotherapy has historically been always, kind of this area that we really didn't touch for a long time, really for many, many years in the early days of radiotherapy, except for palliation, because there was a lot of fear that radiation could cause what was called in the early days radiation hepatitis. Ironically, a paper from Stanford, a pathologist described this entity in this 1965 paper. And I think that scared a lot of people into thinking we probably shouldn't use radiotherapy normally. And so it really wasn't a thing for quite a long time. But actually, interestingly, investigators here at the University of Michigan were actually some of the first pioneers to show that with the improvements in technology and with 3D-based radiotherapy, you could actually, do what we know today, which is that you can treat certain parts or subvolumes of the liver to very high doses safely. And so what do we know now with the world of SBRT for the liver? It's routinely done. I don't know if any of you do that in your practices, but the way I think about it is liver tumors can either come as primary tumors, so tumors that come from the liver, so hepatocellular carcinoma, HCC is the most common. Cholangiocarcinoma or biliary tract cancers is the other type that's also very common. But then the other big component of liver tumors we see are the secondary tumors, the metastases from colorectal metastases, from lung cancer, from other sites, so pancreatic as well. So they are both sources of liver tumors that we might do SBRT on. And I actually think about them differently because these are really two different patient populations. Patients who have HCC, the major risk factor that causes that is cirrhosis, right? And cirrhosis can come from, alcohol, from hepatitis, from all sorts, potentially other inborn errors of metabolism. And so these livers are not healthy. And so you will be limited by how much radiation you can give because those livers with underlying cirrhosis do not tolerate radiation as well. Whereas patients who have metastases or metastatic disease, generally, their livers are perfectly good, perfectly healthy, perfectly normal size, and they can tolerate radiation quite well. And that's fortunate because there are going to be some differences in what we know about how these tumors respond to radiation doses. So I kind of think about them separately, and I break it up here thinking about liver metastases first, which is what do we know about dose? Because we've done this for quite some time, and we've learned a lot about how much dose we can give and how much dose we should be giving. And this is one of the earliest studies to really show that there were some liver tumors, particularly liver metastases, and in this particular case, actually colorectal metastases, which you think about, that's a very common source of liver metastases is from the colorectal cancers. And it showed that you actually need a pretty high dose of radiation to get good local control, which we defined as 90% at 1 year. And based on data that we pooled from a number of institutions, we showed that you needed a BED of about 117 gray. And if you translate that, into fractions, that comes out to 48 gray in 3 fractions. So you would need that high of a dose, 16 gray times 3, to be able to get a 90% 1 year local control. There were some other studies that, looked at the same question. They used other data. This is one from, I believe it's from Colorado and Virginia. This is a pretty old study now, but it looked at melanoma and renal cell carcinoma. And these are two historically pretty radio-resistant tumor histologies. They used a whole, range of different fractionations here, and they looked at their data. and they did a similar dose response curve model, based on their data. And interestingly, they found very similar results to what the colorectal study earlier showed. Basically, you need depending on which model you used, you basically needed either 48 or 49 gray in 3 fractions to get a 90% 1-year local control. So that's pretty interesting, right? So colorectal metastases are as radio resistant as melanoma and renal cell carcinoma. And when they put that data next to like the data that they have for lung cancer lung SBRT has had pretty good outcome, and the tumors seem to be actually pretty radiosensitive with good outcome here. And that's what this kind of this green line is. And you can see that it's much more to the left of the survival curve here. And you can see here that when you combine colorectal next to renal cell melanoma, they actually have, you almost need the same amount of dose to be able to get control. So that tells us that colorectal metastases, for whatever reason, seem to be pretty radio resistant. Other data that we have, this is a meta-analysis from 2018. This is from the Quantec publication, but they looked really kind of at the difference between liver cancer versus metastases. And you can see that the local control is definitely higher for primary liver cancers. You can see that they're, around mid to high 80% at, 3, 4, 5 years, whereas metastases, you can see that the local control is much lower. And if you look if you look at the liver metastases based on dose, you can see that when they break it out by getting 100 gray BED higher or lower, you can see that getting above 100 gray BED is very important to be able to maximize your local control. They did kind of further dose analysis showing that for primary liver tumors, getting 60 to 72 gray BED had a 2-year local control of 90%, which is quite good. So that would translate to roughly about 8 to 10 gray times 5. So 40 to 50 gray in 5 fractions. Whereas for metastatic disease, you can see here, kind of troubling, that you would have to get, they wrote down 180 gray BED to get 2-year local control of 90%. That's a pretty high dose. I don't quite know how you can get to that high, but it just kind of shows you that you can see the stark difference between the doses needed in order to control these different types of tumors. More data that for colorectal specifically, these actually came out in the same issue of the Green Journal in 22, but these are patients with oligometastatic colorectal cancer to either the lung or the liver. And in this study, this was specifically to the lung. But the reason I highlighted it here is because they both pretty much come to the same conclusion, which is that to maximize local control, in this case, minimize local recurrence, and in this case, to maximize local progression-free survival, you basically needed at least 120 gray to be able to get to that, to maximize that, or that's the group that had the best local control. So, again, I think it's pretty sobering data to show us that how important the dose is going to be. For hepatocellular carcinoma, I'll probably skip this just to kind of keep things moving along. Just know there's lots of different options for treating HCC that have emerged because radiation was, kind of late to the game, but also it is one of the many liver-directed therapy modalities that are out there. The role of external beam can certainly be used when other liver-directed therapies are contraindicated. You could use it for salvage if other liver-directed therapies fail. You could do combination of chemoembolization, for instance, and an external beam if you wanted to treat the whole liver, which most of us don't do. Or you could do chemoembolization and external beam radiation if for tumors that have portal vein thrombus, if they're starting to go into the portal vein. It is in the NCCN guidelines. This is for, treating hepatobiliary tumors. You can see external beam, whether it's conformal or stereotactic, is one of the local regional therapies that are recommended for unresectable HCC. The data generally, as I said before, remember how poor the local control was in the metastatic setting. It's kind of the opposite for HCC. You can see the local control rates are, routinely above 90%, whether it's 1 year or 2 years. And there's data now that goes to 3 and 4 years, and the local controls are quite good. So for whatever reason, HCC is a much more radiosensitive tumor in the SBRT setting. So the question is, how does SBRT compare to other modalities? Well, we know that SBRT is better than chemoembolization. This was one of the first studies that came out comparing the two. This is actually from the University of Michigan. They retrospectively looked at patients who were treated with SBRT versus chemoembo. I think the curves speak for themselves. You can see SBRT has an extremely high rate of local control, whereas chemoembolization does not. And interestingly, too, the improved local control with SBRT also was associated with better liver progression-free better liver progression-free survival, meaning that if you controlled the tumor, you also had a lower risk of other tumors emerging elsewhere in the liver. So that's kind of an interesting concept. This was a proton prospective randomized trial that asked a very similar question, basically proton radiotherapy, 70 gray in 15 fractions compared to chemoembolization. Again, you can see significant improvement of proton versus chemoembolization. Now, you might say, well, oh, sorry, one more trial, the trendy trial, very similar. So I think you get the idea that high-dose radiotherapy is going to be much more effective than chemoembolization. But what people might say is that, well, chemoembolization is not an ablative treatment, right? It's not meant to kill or ablate the tumor and control it. So it's not really a good comparison. So what's a better comparison is SBRT against something like radiofrequency ablation, and because that uses heat to kill the tumor, and that is meant to be ablative. And so this was actually one of the first studies that came out on this topic, also from the University of Michigan, a retrospective study where they compared patients who were treated with SBRT versus tumors that were treated with radiofrequency ablation. And what they found that overall, there was no difference in local or freedom from local progression. But when they broke it down by size, for tumors less than 2 centimeter, this curve is not significantly different, no difference in freedom from local progression. But for tumors greater than 2 centimeters, you can see that SBRT actually had better outcome, basically better freedom from local progression. And this is just showing kind of the hazard ratio. As the tumor gets bigger, the hazard ratio goes up, which is favoring SBRT. So that makes a lot of sense, because if tumors get too big, the RFA is not going to be effective. Interestingly, a study was just reported late last year, is a prospective randomized trial from China. And they basically asked the exact same question now in the prospective setting, RFA versus SBRT. And the funny thing here is they actually found the opposite. They actually found that for small tumors, well, generally they found that SBRT was better than RFA, but what they found is that for small tumors in particular, that difference was significantly pronounced. So basically, you can see the curves here, local progression-free survival between RFA and SBRT. SBRT is higher, and this is basically if you break it down by size. But here you can kind of see it graphically here. Local progression is the red, and the blue, I guess, is control. And you can see for RFA, you can see much higher rate of local progression compared to SBRT. When you look at it based on size for tumors less than 2 centimeters, you can see that local progression was higher with RFA than it was for SBRT. So pretty interesting finding. And then here you can see on the forest plot, you can see that plays out right there with a hazard ratio of 0.39. So I guess the takeaway from that is I just think SBRT is better no matter what, whether it's large or small. What I mentioned before about MR-guided radiotherapy, the same principles can apply, because if you're treating a tumor that's very close to the stomach, this could be an opportunity where adaptive radiotherapy could help. And so many investigators with MR-guided technology, they have been using this also to treat liver tumors. Plus, you can oftentimes see the tumor better when you align these patients, and that can help you with better accuracy. And so that's, is shown here with some clinical data. This is a 6-year experience from Washington University. They were early players, early adopters of MR-guided radiotherapy, and they reported on about 100 patients with HCC, cholangiocarcinoma, or mixed, treated with 50 gray in 5 fractions, so a pretty high dose. And more than half of these patients, the PTV was within 1 centimeter of the duodenum. And so that allowed them to be able to adapt the plans, and about, pretty much that same number of patients had their plans adapted. And the big thing here is that you can see that the local control, or local failure rate, I should say, of the tumors was basically less than 10%. So high rate of local control with this treatment. But the big thing is that if you look at the toxicities that they scored here, you can see that they all are generally quite low. Grade 3 toxicity was the most common late toxicity, but very few grade 4 or grade 5. And you can see a lot of them were really just more like transaminases or elevated enzymes. But overall, the toxicity was quite low. So this supports the role that MR-guided radiotherapy could have for these patients. Okay, so question 4. Which of the following is true regarding SBRT for liver tumors? Metastases, oh wait, hold on, gotta move this. Metastases are more radiosensitive than HCC. SBRT has worse local control compared to RFA for HCC. SBRT for HCC has superior local control compared to transarterial chemoembolization. Or D, adaptive radiotherapy has been shown to be associated with higher rates of toxicity. Let's see how the group is going to do.
It's going well so far.
Almost there.
Yeah, almost there. So a few more answers, please.
One more push.
Yes.
All
okay,
right.
ending the poll sharing results. So majority, 53% answered C.
Yes, that is correct. Great job.
Yes.
Obviously it's the opposite. Mets are less radiosensitive than HCC. SBRT has better local control compared to RFA for HCC. C is correct. And D, I was trying to show that the adaptive radiotherapy is shown not to have higher rates of toxicity. So hopefully that was clear. I'll try to go through the last section as quickly as I can because I know we're at 2 o'clock. I want to make sure Dr. Paradis has time to speak. Toxicity is the big concern. And there's really 2 models that have emerged for liver toxicity that we use. There's the critical volume model, which is really, the concept is just, can you spare a certain amount of liver from receiving ablative radiation so that they can, it's enough for their liver to live on. And that's very much kind of analogous to like the surgical experience. A surgeon can remove a third or a half of someone's liver, and as long as they leave them with enough liver, then they will be okay. So that's one concept that's very intuitive and easy for us to understand. And this has really been primarily emerged for liver metastases. I think we've used this historical LKB, the NTCP model. This actually originated from the University of Michigan. But it really kind of uses some complex modeling to convert whole organ tolerance doses into estimates based on the partial volume radiation. You don't really have to get too much into the math because I think they've simplified it since then. I just kind of showed you here, like this is what the original model looked like. And I've read this paper many, many times and I still don't understand it. So I don't really use it, but it's just to let you know that this is what it is. But really, these are kind of how these 2 models compare, which I won't spend too much time on. The big thing here is critical volume seems to work quite well for metastatic patients. These were some of the early studies that used this concept, and they came up with the constraint of making sure you can spare 700 cc's or 700 milliliters from receiving more than 15 gray in 3 fractions. And that was the one that was originally used, and these were the papers that followed that. And when you gave in these 3 studies, when you did that, whether it was 15 gray for 3 fractions, 21 gray for 5 fractions, there were no rates of toxicity. Interestingly, in the study by Mendez Romero, they actually had 2 cases of grade 3 toxicity. And when they looked specifically at those patients, they actually found that less than 700 cc's were spared from 15 gray. So that kind of helps to reinforce that maybe this constraint that we have seems to be pretty good. The other concept that I had helped did some studies on was really, what about this concept of central liver toxicity? This was based on the experience from the lung cancer data, where if you treat really high doses to the central part of the airways, there was this really dangerous risk of severe toxicity and even deaths. And so the question is the liver, which has a very similar organization to the organ, do you have that same problem? And so we did a study where we looked at kind of the central region, specifically the liver, to look at the dosimetry, and we found that there was indeed a higher risk of what we called central hepatobiliary toxicity based on the dose that we received. And after we did a bunch of calculations and modeling, we found that, these were the ideal dose constraints that we wanted to try to meet. This central hepatobiliary toxicity, we wanted to try to keep the V21 less than 45 cc's, less than 45 cc, and the V26 less than 37 cc. And the 15 is an indication that what we do is we actually take the portal vein and we actually put a 1.5 centimeter or 15 millimeter margin around that structure, and we call that the CHBT. So that's the structure that we try to spare those, we try to meet those dose constraints. In terms of overall dose constraints, we had proposed these many years ago in an issue of Seminars Radiation Oncology. Obviously we know that if the liver is non-cirrhotic, it can tolerate radiation differently than if it was cirrhotic, and so we had different dose constraints for that. And then, of course, we included our central liver constraints. Since then, more recently, Astro has published their clinical practice guidelines. So if you want, you can refer to this. I think this is actually quite good. It breaks it out if you do 3 fraction versus 5 fraction versus 15 or more. And so I think this is actually a pretty good resource. Lastly, dose guidelines. I think we talked about before, if it's metastatic patients, particularly the radio-resistant histologies, colorectal, renal cell melanoma, I try to get very high doses if I can. 48 to 54 gray and 3 fractions is what my preference is. If you can really try to get at least 45 and 5, but I try to get at least 50 if I can, 50 and 5, if it's not safe to do 3 fractions. If it's a less radio-resistant histology, breast cancer is one that, seems like it actually gets, it responds nicely to SBRT, 45 and 3. Otherwise, if you can't do 3 fractions, 40 to 50. And for HCC, if you can do it safely, 45 and 3 fractions would be pretty sufficient, although we've even lowered that some more down to 39 or 42 gray and 3 fractions sometimes. But if you really feel like you cannot do that because of dose constraints, 30 to 45 gray and 5 fractions if you're a child Pu A. But if you're a child Pu B, these patients are going to be in much worse shape. And so I would not let the doses go higher than 40 gray and 5 fractions. And then cholangiocarcinoma, biliary tract cancers, I didn't talk too much about this because I didn't have time, but these are kind of my recommended dose constraints. Tumor treatment planning process, not very different from that for pancreas. I think the big thing, again, is biphasic CT, meaning you need the arterial and the venous phase, particularly for HCC, because HCC is the tumor that blushes with the arterial phase, so you need that to be able to visualize the tumor. So you either use a diagnostic scan, or if you can scan them that way on your treatment planning scanner, that's what you would want to do. So my last question, and then I'll turn it over to Dr. Paradis. When planning for liver SBRT, which of the following is true? HCC should always be treated with 5 fractions or more. Liver metastases should receive a BED of at least 100 gray. Respiratory motion management is not required. Patients with child Pu B should never receive SBRT.
All right, so we are ending the poll, sharing results. So 51% answered B.
And that's correct. So A, I said you could do 3 if you think you do it safely. That was one of my dose recommendations. B is correct. C, of course, obviously you do need to have respiratory motion management because the liver moves just like everything else in the upper abdomen. And then for D, you can treat child Pu B cirrhotic patients. You just have to be very cautious and probably have to use a lower dose. So conclusions, let me just see here, get them all out here. SBRT for liver tumors remains an important local therapy. Metastases, particularly colorectal cancer, require higher doses. Prospective trials are needed to compare SBRT with other established liver-directed therapies, and adaptive radiotherapy could be an important modality to ensure effective dose delivery while minimizing treatment toxicity. So that is mine, and I will stop there, and I will let Dr. Paradis take over, and hopefully there's enough time afterwards for some questions.
Excellent. Thank you so much, Dan. Excellent presentation. You're a great teacher.
Oh, thank you, Kelly. Kelly, Natalia. Thank you, Kelly, too.
Both of them.
All right. I'm really happy to be here. Thanks for the opportunity to participate. And I'm going to be quick because I feel like other people already did the majority of my work for me. So thank you, Dr. Chang, and thank you to the earlier presenters. So yeah, when I was getting ready for this talk, I wanted to go back and see what you'd already had in this series, because I didn't want to just be repeating, a lot of the same information again. And I wanted to highlight these three fantastic presentations that came early on. The recordings are on your website, so thank you. I actually sent these to our residents because I think they're so fantastic. But these covered commissioning and QA, immobilization and motion management, and then there was a whole lecture on treatment planning. And there are a lot of things in there that are specific to liver and pancreas SBRT. So definitely go back and check that out. And I won't take up your time repeating that. So I thought today something that might be useful was to spend a little bit of practical time thinking about planning quality and how we evaluate it. So one of the things that you already heard from Dr. Chang is that overall survival and local control for these patients is going to depend on the dose that we can deliver. And of course, one of the purposes for using SBRT in the first place is that we want to achieve these higher ablative doses. But the dose that we can deliver, whether we're talking about liver or pancreas, it's going to be limited by our normal tissue tolerance. So how are we going to know, like, let's say we're sitting down, we're looking at a treatment plan. How do we know if we have a good balance between target coverage and OAR sparing? And so the reason I bring up these earlier lectures is because they really covered the foundation of this. So we want to make sure that we have characterized the precision of the equipment that we're using, so we know what kind of margins we can safely apply. We're QAing that equipment regularly. We're using the immobilization and motion management that is indicated depending on what type of patient we're treating. And then I think in the treatment planning lecture, someone made a really good point that we have to make sure that all of the team members involved understand their roles and they know what are these specific considerations when we're talking about SBRT and how it's different from the other treatments. Okay, so let's say that we have that foundation in place and now we are looking at a treatment plan and we want to know, okay, is this a good plan? Can I use this? So as you heard, of course, from Dr. Chang, this is going to start out with basic things like looking at our dose volume metrics for our target coverage and our OAR sparing. When we're talking about plan quality in liver and pancreas SBRT, we're also thinking about these plan quality indices like conformity index, homogeneity, and our gradient indices. Things like how far is our dose spilling out? So like V50 and V30%. And then Dr. Chang also talked about these OAR constraints. There are lots of resources that are out there and they do change from time to time. So it's hard to say like this is the answer, this is the constraint that you want. But these are some good resources that you can take a look at online. And then just to go into a little bit more detail on the resources that are out there. So ASTRO has practice guidelines specifically for liver and pancreas SBRT. And other body sites as well. So you can get them. I put the link on here, but you can also just Google ASTRO practice guidelines. You can look at things like current clinical protocols that are out there, for example, from like NRG or RTOG. Dr. Chang mentioned several of them. One thing I did want to mention is that you can find papers that are technology specific, and sometimes that is really helpful because in your own clinic, you probably don't have a lot of control over what technology you're using. You have what you have, and you want to use that to the best of your ability. Or maybe you want to, you saw Dr. Chang talk about how adaptive radiotherapy can really be beneficial, and you want to bring that to leadership to try to negotiate for new equipment. But it's very helpful to understand what the equipment that you're actually using can achieve, because whether you have, for example, this one is about MR guided SBRT, but if you don't have a machine that does that, then you're going to be looking at different kinds of treatment quality indices. A resource that I really like is this series of case examples that are in Practical Radiation Oncology. You'll see a name you recognize here. So this is from the Radiosurgery Society, and they have a whole series of these papers. So this is the one specifically about pancreas, but they're all fantastic. And what they do is they present one or a few challenging cases, and then they talk about how they might address those cases in a very practical way. So really fantastic series of resources there to check out. And then, of course, things like review articles. I picked this one out from Cancer. This is about primary liver tumors. So I like these because, as a physicist, I might not be as familiar with some of the clinical aspects, and I like having access to these review papers because they're kind of pulling it all together for me, and I see all the resources in one place. So that might also be something that you find is useful. Okay. So I know everybody here knows that we're supposed to compare our plans against established metrics. But a point I wanted to make is that it's also important to be aware of what your institution is typically achieving in treatment plans, because you want to be able to notice any outliers. And the reason for this is because your data are going to be tailored specifically to whatever equipment, whatever technology you are using. So for example, just very simply, something you could do is to create a histogram of conformity and gradient indices calculated for, say, a cohort of prior liver SBRT plans and prior pancreas SBRT plans. Or if you're starting a new program, you could do some practice cases and see what you're achieving. And so in that way, when you're looking at a new plan, you can tell right away if it is falling into that typical range. And then if you want to take that another step farther, you can start separating your data into different groups or cohorts based on patient-specific factors. And that's things like target size, shape, how close it is to organs at risk. And so this is starting to get into a concept called knowledge-based planning. And I find it to be especially useful for the body sites that we're talking about here, because those plan quality indices that you might see in papers, it's recommended you achieve a specific number for conformity. You're going to get a different number depending on whether you have, say, a small spherical target at the apex of the liver versus a large complex target that is surrounded by overlapping OARs. So it doesn't make sense necessarily to expect that you're going to get the same results in those two situations. Probably some people are aware that knowledge-based planning is available commercially from some vendors. One of the more well-known ones is called Rapid Plan from Varian, but you don't need a commercial tool to be able to implement this. So like I've been saying, you could gather data from your own prior cases, or you can look at these published resources that I've been showing you, and then you can compare your plans against those metrics. But so Dr. Chang got into this too. There is a lot of evidence out there showing how important plan quality is for patient outcomes. And we also know that knowledge-based planning does improve quality. So for example, I put a recent paper on here that's from Green Journal that talked about knowledge-based planning for 10 different body sites. And they showed that almost all of the time, the physician who was reviewing the plan thought that the automated plan from KBP was acceptable. If you are an Eclipse user, and again, not required, but if you are, there are free, publicly available knowledge-based planning models that you can use. So there are a whole bunch of them on the Varian Medical Affairs website. And then University of California, San Diego also has this one down here. It's called Orbit RT, where they have their own models on there, and both for liver and pancreas SBRT. And then even if you're not using Rapid Plan, a lot of these models come with PDFs that explain like how is the model made and what were the important aspects. So you could still look at that and look how they were planned, and incorporate that into what you're doing if you find it's useful. And then, going one step farther on this, one of the things that I am hoping to see in the near future is the ability to upload anonymized patient planning data and then get back an assessment of plan quality. And at the same time, I'm thinking that we're going to see more investment in planning automation from commercial vendors, because in that way, we're going to be less dependent on user experience in terms of how plan quality turns out. But in the meantime, before that is available, you can use these strategies no matter what technology you have to implement this at home right now. All right, and then let me just really quickly summarize this. So in terms of plan quality, definitely check out the recordings of those earlier presentations. Those were lectures 2 through 4. That was a fantastic overview and foundation. Moving forward, you want to make sure you know what your institutional standards are for plan quality, depending on the type of case that you are looking at. Because the quality metrics that you're using are going to be dependent on your own unique setup. It's going to be based on your treatment delivery technology, your mobilization, the motion management that you have access to. So we're not just looking at the published guidance, but also what you are achieving at your own institution, whether that is on your prior cases or test cases if it's a new program. And then I had also recommended that you think about looking at these metrics for various patient geometries. So that's starting to incorporate the knowledge-based planning, whether it is with one of those commercial products or just on your own. Either way works. And that way you're understanding, what you can achieve. And then also, looking at those published reports, especially like if you're only able to look one, I would go to that case series in Pro, because they do a great job of focusing on the practical and what's important. And then finally, I would say I am a big proponent of automation. Any kind of automation that you can implement, whether that is in your workflows, your planning, your contouring, those types of technologies really help us with this process, no matter what type of clinic we are working in. And so just to give like a very brief example, if we're trying to compare OAR doses across plans, we want to compare it and see if we're meeting the objectives that like Dr. Chang showed on his slides. We have to make sure that we actually contour those OARs correctly and that we do it the same way each time, especially when we're talking about volumetric objectives, like some of the ones that are important for these types of treatments. So there are commercial solutions out there for this, but you don't have to have those specialized technologies in order to implement knowledge-based planning in order to be safe. What really matters the most is having a good understanding of the types of plans that are achievable with the technology that you're using, so that you can right away see spot any new plans where we are not meeting those objectives. I think, we're nearing the end of the time, right? Should we stop and open the floor for questions?
Yeah, thank you so much, Kelly. Thank you for a nice presentation. I'm opening the floor for questions. If you would like to ask a question, turn on your camera, microphone, or you can also type a question. I will read it. So while people are maybe thinking, I'm curious then about the celiac nerve plexus treatment for pain. Can you talk a little bit more about this? So you briefly mentioned.
Right. Yeah. I'm sorry I didn't have time to talk about it. I mean, there's a few slides on this now, but there's actually 2 studies from Israel, interestingly enough, on looking at this
Mm-hmm.
topic. One was retrospective, pretty small, but they were able to confirm that with a larger prospective study. It was in Lancet Oncology, I think, last year.
Mm-hmm.
But it did show, the numbers are escaping me, but they based it off of, looking at pain response, like the pain score, a significant drop, which I think like 2 or 3 points drop in the pain score after a certain number of months, like 2 or 4 months, and also the opioid use, the need for opioids. And you get delivering, I believe that was 25 gray in a single fraction to this
Okay.
target that they defined along there. And, it was actually looked really exciting. And it
Mm-hmm.
really does kind of open the door, I think, for more this concept of, for those that, may not know, our ASTRO, the American Society of Radiation Oncology has become very interested in sort of expanding the indications for radiotherapy. And I think this.
Right, about beyond cancer, right? So
Correct.
that fits into that. Do you know of any trials started in US?
In the US, I'm not sure that there is any yet. I know there's someone has talked to me about one, so I think that there is a lot of interest in getting that going, but I'm not aware of one that's open right now.
Oh, excellent. I see 2 questions in the chat. Thank you for the wonderful detailed lecture, Dr. Chang. You said that the reason for increase in pancreatic cancer incidence is currently unknown. Are there any studies showing or trying to show correlation with type 2 diabetes or insulin resistance?
Yeah, great question. Yeah, it is, like I said, it's scary that we don't really
Yeah.
know why.
Mhm.
But there absolutely is a correlation between adult diagnosis of diabetes and being diagnosed with pancreatic cancer within, a certain number of years, like within 1 year, I think is what some of the studies that I've seen showed. Um, I'm not an expert in this, so I don't know like the latest data on this, but I'm sure there's some correlation there, but I don't know what the science or mechanism is behind it. But I do think that is something that absolutely is worth exploring. The problem is a lot of people are diagnosed with diabetes, and pancreatic cancer still is not that common. So I think it would be very difficult to like I don't want people to think like, oh, I got diagnosed with diabetes, now I'm going to get pancreatic cancer. That's not what the data is showing.
But the risk is higher, right? That's what the data showed,
The
that
risk
the
is
risk is
higher.
higher.
And there is a large number, I don't know large, but there's a noticeable trend in patients who get diagnosed with pancreatic cancer. They were diagnosed with adult onset diabetes, kind of in the recent past. So it's very interesting stuff.
Mhm.
Hopefully more.
That's why the numbers are
Yeah,
rising, right?
right.
So there's a question from Jeff also. Thank you for this excellent talk. The BD formula works well for conventional fractionation. What are your thoughts on applicability for BD formula when considering hyperfractionated more than 10 gray per fraction regimens? Do alternative biological mechanisms like immune response, vascular ablation, hypoxia, reoxygenation reduce the usefulness BD formula these hyperfractionations?
Yeah, that's a great question. We have those. I remember in the early days we made a big deal about this because again, we all know that probably the standard BD formula doesn't really apply. The problem is we don't have something that works better. I think when we talk about like 40 gray or 50 gray in 5 fractions, we don't really have any common language other than using the BED formula. So for now, it just seems like we've all kind of gotten comfortable with it and use it. There was at one point this universal survival curve that Bob Timmerman did back in the early days, which was trying to adjust for some biological modeling or something that they incorporated, which I don't necessarily think worked, and no one's really adopted it. So I'd be welcome to, obviously have something else that works better, but part of it also has to be very easy to use, right? And being easy to use also, we have to kind of factor that in too. I think that your point about by alternate mechanisms, immune response, all those other things, I mean, those of course will have some impact, but I leave it to the radiation biologists to help us kind of figure out and answer that question.
Yeah, there's still a lot of unknowns there in this area,
Sure.
right?
Great question.
Yeah. If I could just add to
Yeah.
that too, this is something that we think about a lot in the reirradiation space.
Mhm.
It comes up. And yeah, Dan already said this, but there's just so much that we don't know and understand. And I don't know if this question was directed specifically at like dose to targets or dose to OARs. But these new papers, like the high-tech series, do a really good job of, modeling in these higher dose per fraction regimes. And so I think a lot of that data helps us. And as long as you're looking at data that comes directly from SBRT, as opposed to like taking, say, a Quantact standard fractionation dose limit and then translating it over to SBRT, you'll be more successful. And at Michigan, even in the higher dose per fraction regimes, we are still using the linear quadratic model. But again, that is because, Dan already said this, it's because we don't have another option. It's just the best model that we have right now, and it's the most widely accepted.
Okay, thank you, Kelly. So I want to remind everyone that you have a homework. It's obviously optional, but it would be great for you if you can complete. So there's one case that the Michigan team uploaded. Thank you so much. So one is pancreatic cancer case, and another one is a liver SBRT case. So you can download those, practice contouring, practice planning. So this some of them are quite challenging, quite interesting to plan because there's an overlap I see with the duodenum, right? Yeah. Do you want to talk a little bit about this, Dan?
I can, but I do need to go pretty soon. But
Yeah,
I can,
sounds good.
hopefully it's in the vignette. But this case is an HCC, and I purposely picked it because it obviously is very close to the duodenum right there. So it's a bit more challenging. And I can't remember the pancreatic case we gave, but it's a pretty straightforward one, I think, if I remember correctly. And you should hopefully be able to see it pretty nicely along with the the primary tumor, and hopefully everything's turned out well. So
thank you so much. Thank you. Srihi, you have a question?
Thank you very much. Yes, I do have a short question, if I may. Thank you very much for the great lecture. I do find it more and more challenging when is this so-called parallel structures, as liver, for example, we consider then structures. You mentioned, I think, portal vein, but I wanted to ask about the consideration of any type of vessels for both localizations, for pancreas or for liver, when you have proximity to the vessels or when you have invasion. What are the considerations then about doing or not doing SBRT?
Yeah.
And also, if how do you contour actually portal vein? Is it in some auto contouring? Is it easy to find? I think not that easy to find on CT, maybe on MRI fusion, or how do you do that?
I contour it manually just because I think if you have contrast, you should be able to find the portal vein pretty well. Sometimes it can be challenging if like the tumor is invading or distorting it. That can be sometimes challenging, but otherwise, with contrast, you should be able to find the portal vein pretty well. But the bigger answer to your question is I don't worry. For the most part, I don't worry about the vessels. The vessels can tolerate radiation very well. You heard about, the celiac axis ablation. I mean, you're giving 25 gray celiac, and it does perfectly fine. From our single fraction experience, we never really saw any toxicities. I suppose there's a theoretical concern of an aneurysm if you treat the aorta to a really high dose. I have never seen or heard of that ever happening, so I tend to not worry about it until it actually happens. The only scenario where I could imagine being a little worried is if the tumor was like directly invading into like the aorta or something like that, where I don't think I've seen a case like that, but there's a theoretical concern that as the tumor responds, then obviously you'll leave this big hole in the aorta and then the patient could bleed out. It wouldn't really be true of pancreas because pancreatic cancers, I didn't talk much about this, but they don't really respond much to the radiation. It doesn't like shrink or pull back. It just kind of freezes in place. And so that's never really been a huge concern. But if I had like, I don't know, like a I don't know, lung cancer or something, or a lymphoma, certainly a lymphoma, if it was doing something like that, I would be more worried. But it's just never come up before. So it hasn't been a concern of mine.
Thank you so much, Dan. I know you have to run. Thank you. Thank you both for the great lecture. I'll see everyone next week. Bye-bye. Thank you.